I've got some cuties.
All right, let's see what you got.
So this is a woman who had a defibrillator placed, I think, in 2013, quite a while ago. And this is what things looked like. Actually, this is before then. This was 2010. And over the years, she had the sensation that the pulse generator was slipping lower. So this is then. This is shortly after it was placed, so the arm is still down. They don't like to tear the pocket, so they keep the arm down on that first lateral radiograph. So that was then, and then this is now, and she has some redness and tenderness at the site. You can see that this thing indeed has slipped way down into her left breast. So on lateral view, you can see it's really down there in the sort of the body of the breast. And this is native breast tissue. This is not an implant or anything like that. She's not had breast surgery. So indeed, the radiography suggests what she has suspected over the years, but she hasn't been quite sure about it. Now she has redness and tenderness, so she is scheduled for a pocket revision. But this thing has just worked its way down into that left breast over the years. So the young woman, and you know, she's not an older woman who has really flaccid breasts and very loose connective tissue. She's a young woman, so there's no connective tissue reason for this, just perversity. Okay. So here's a woman with chronic shortness of breath and pulmonary hypertension, and she has this radiograph here. You can see the differential lucency of the left lung compared to the right. So looks as if there's attenuation of all the vessels here. The lung is a little darker than the other side, and the mediastinum is a little shifted to the right. Her problems go back throughout her life.
It's radiology.
And this is a CT scan that shows some cystic abnormalities, some parts of the lung here that have this gross attenuation without sharp margination. So it really looks like emphysema sort of pattern in this lung, or profound air trapping. She does have quite a bit of air trapping on expiratory views, and lobular air trapping on the right side, I think, is more readily available, but you know, very big areas here. And indeed, her pulmonary artery is big compared to her aorta. She does have pulmonary hypertension. So it turns out that she was a preemie. She was in the neonatal ICU for a long time on a ventilator. And this is the second case in the last month. I showed you guys a case in December of BPD, bronchopulmonary dysplasia. You have the neonate, which is these days not so much scarring and gross architectural distortion of the lung, but more often to be air trapping, emphysema-like things, and pulmonary hypertension. So pulmonary hypertension sometimes by itself is one of the manifestations. So Jeff was commenting last time that the old bronchopulmonary dysplasia was very scarred up lungs, looking like post-ARDS lungs with cysts and things like that, lots of scar tissue. This one has a lot of air trapping, some cysts, but not a lot of scarring. But this indeed is bronchopulmonary dysplasia. And in her case, unlike the case from last month, pulmonary hypertension is a prominent component of her disability. So BPD in this, I think, 28-year-old woman. And then I would like to show you a couple of cases. This person has a mediastinal mass here. I tried to get an old radiograph for comparison, but for some reason I can't display it to you. But this blob was not here at this point. She does have a port catheter in place for chemotherapy, and then you'll see that she has a reason for these lumps. She's got a lot of mediastinal tumor here, these big, well-defined blobs here in the mediastinum, subparietal region here, and then paraspinal down here. Not seeing a lot of bone erosion or anything like that. So, and she's got a right hilar mass as well. And if we go down into the liver, she has this low attenuation liver lesion back here, which was biopsied. And what do you think they got out of this?
Some of that tissue in the basal right hemithorax paraspinal looks like it's growing in the extrapleural space, I think.
Yes, I agree.
So one should think of lymphomas,
Right.
lymphoproliferations, rather than, say, metastatic from an adenocarcinoma when one sees that.
Yeah, I like that. I think lymphoma is the best candidate for this. And this turns out to be myeloma. So this was the biopsy here returned plasma cells. She was a relapsed myeloma person after a autologous stem cell transplant. So this is relapsed myeloma, and plasma cells, at least from the liver, presumably the plasma cell tumors elsewhere too. So this would be extraosseous myeloma. Okay.
Yeah.
And then let me show you this case. I have a scout view for you, but not a plain radiograph. This person has pleural effusion and maybe some mediastinal lumpiness, but maybe this is just effusion lapping up against the mediastinum. And on CT, she has mediastinal mass, anterior, a lot of chest wall or pleural lesions here. Bones look okay. And here's a big pad of tumor here anteriorly. And this is also relapsed myeloma. So another case of extraosseous myeloma, we've got pleural tumor here. So this is pleural myeloma. Mediastinal, this one doesn't have obvious lung component like the last one. And I think there's some chest wall stuff that showed up down here in these paraspinal muscles posteriorly. Maybe it was the other case. So widespread infiltration, you know, when you see tumor this widespread, you think first of lymphoma, and this turns out to be plasmacytomas. So another case of extraosseous myeloma. I think this makes about 20 that we've seen here.
Yeah.
Does it behave any differently than the initial phases, other than it relapsed and failed treatment?
Well, you know, I'd really like to pull together the stats on our cases and see how many of them were relapsed rather than primary presentation. So I think it's a very good question. I have a feeling that the ones that relapse are the ones that are more aggressive, and maybe it's the more aggressive that predisposes to this soft tissue infiltration, not just sticking to the normal, you know, bone compartment.
Interesting.
Okay, guys, those are my cases. Thank you.
Well, thanks. All right. Who wants to go next?
I can go. It's been a couple weeks.
Yeah.
Let's see, did you give me access?
Claims I did. Let me take it back and then send it to you.
Yeah. I may have to restart this thing again. Yeah, I'm gonna have to restart again. Okay, never mind.
All right.
I have to change some other security setting.
Want to go next?
Yeah, I can go, Jeff, anytime.
All right.
I'll start with this one. This patient on a particular day had a CTPA. You can see from these images here that they're using a bolus tracking protocol. They have the cursor there. They have set a certain trigger for scan initiation, or at least, scan initiation, scan delay or something. And we have a CTPA that looks like this. So I will scroll through that and see what you see. So no PE is present, but there are other findings. There's a small effusion, but now pay attention to the aorta in particular as I scroll back up. Descending aortic root.
So the root is really big, and there's maybe a plane in there, like right there. Something looks funny. You're above the valve right there, so there's something funny
All
at
right.
the proximal
Very
root
good.
or proximal ascending.
Okay, very good, very good. I'm slowing down at a certain part here intentionally. Streak artifact.
Yeah, but then you've got a linear low attenuation area that follows the long axis of the aorta there.
Okay, very good.
So is there a dissection in there?
You'll see. Lung opacities, symmetric, both lungs. Pleural fluid, small, both sides. CTA was done with a delay of about a day. There it is. Now, and here. Now, this also points out the importance of technique and interpretation. So clearly here we have pulsation artifact. It's easy to see the dilated aorta, but even with the pulsation artifact, related artifact along the periphery of the aorta, there are these. And of course, when you see that, and then you see that, yes, indeed, this is a dissection. So if we see findings of an intermedial flap with movement of it because of the pulsation and the motion, and then we see an empty aorta, as best we can tell, and then a flap further here, one should think of a circumferential intermedial disruption. And if that is the case, then with diastole and systole, you may get movement of these flaps. So in the aortic root, in diastole, the intermedial flap may prolapse backward through the aortic valve and prevent coaptation. And with respect to any distal flap, it may, like a windsock, result in an intimo intersusception. So those are things to think of. And then, of course, if you look more carefully, you wonder to what extent some of this actually goes up into brachiocephalic arteries. So the first technical point, again, is, and I showed one 2 weeks ago, I think, that when you do a CTPA, you really do want to opacify the left-sided structures as well, so that you can make a diagnosis of dissection.
But why didn't you gate this? I mean, you guys knew there was something in the ascending aorta.
This was from an outside hospital.
Oh, it was all outside.
Yep. Yep.
Yeah, I think the answer is they didn't know.
Well, they knew on the non-com. No, they did know because there was a PE study where it was suggested on, correct? Or they missed it on the PE study.
I'm going to assume that they didn't make the observations on their CT.
Okay.
But I don't know that. I don't know the thinking of the outside folks. Here you can see that the surgeon did confirm the presence of a circumferential dissection. And I guess the surgeon interpreted the scan himself, but said that he did not see a flap in the aortic arch, so it did a hemiarch, but there is indeed a flap there. So that, even though it wasn't seen during surgery, there is an intermedial flap. So we always have to hope that maybe the surgeons will consult us before they take the patient to the operating room for outside studies. So that was also unfortunate. So a couple of lessons here again. One, we talked about the other week that important to opacify the left-sided structures in the aorta on a CTPA. And then, yes, the technical points about proper opacification, gating definitely helps. And I think this is a case of a circumferential tear with an intimal interception, perhaps up in here, somewhat suggestive of that. So a bunch of interesting features are present. This is one that I saw the other day. This patient was transferred to our hospital from the outside. I think that in the context of a myocardial infarction or NSTEMI, things didn't go well. And he was transferred here with a history of cardiogenic shock. So in looking at this bedside radiograph that we obtained, everything looks fine except for this. So typically when I see that nowadays, one of the things I think of is peripheral ECMO, but that would be odd because this cannula, although it comes up the right way and into the right atrium, makes a turn here and goes to the left side. And one thing that is present on multiple images is that this little dot there is a portion of this device. So it's a cannula, then there's a non-opaque portion, and then there is that. I did not recognize what that was, so I had to look that up. So I learned that this is a device that I haven't seen before called a TandemHeart left ventricular assist device. So I'll just try and fix that up. And at least for this, bring that up. So you can see that there is transseptal passage of this cannula that goes into the left atrium intentionally. And it is a method of circulatory support in which you take out blood from the left atrium and you put it back into the femoral artery. So it's a left atrial to femoral artery bypass system. And they make some comparisons between it and an IABP for cardiac support. But I've not seen one before, so I didn't recognize it. I recognized that it was odd, and then worked out that it was a TandemHeart device, as you can see here. Anyone seen one of those before? I don't know how efficacious it is. Our folks don't use it here, as far as I know.
One of my colleagues looked over and said, "Oh, that's a TandemHeart." I didn't know, but he clearly knew.
Okay.
Yeah, we use it here too at University of Washington. They've been using it for a few years, but they don't. It's not that common. They have other ways.
Yep. Nowadays, in the context of cardiogenic shock, what we do see, and I'm sure you probably see it more often, is a combination of peripheral AV ECMO with an impeller device to decompress the left ventricle. So the combination of the peripheral AV ECMO and an impeller rather than this for circulatory support cardiogenic shock is what I see. Okay. Okay, interesting case. This is a patient with pancreatitis. And you'll see here, I'll just start off by showing you the pancreatitis, rather severe looking pancreatitis. And then he was imaged over a period of time, mostly with abdominal CTs actually, to evaluate pleural fluid accumulation and the abdominal disease. And then what we noticed over time, one of my colleagues, is the pleural fluid, the chest tube, but the interesting finding is right here, interventricular septum and the ventricular wall, calcium. So that is a new finding and accumulated over time. So that is December, early December. This is later on in the end of December, and you can see the calcification there. So myocardial calcifications, we've shown cases of this before. Usually we think of sepsis, we think of renal failure. The only thing that I could find relevant to this is that he did have earlier in November findings of acute kidney injury. He did eventually require temporary dialysis for that. He went on to dialysis, so he did have renal failure, did not have sepsis as far as I can tell, but did indeed develop left ventricular myocardial calcifications. You can see that his cardiac function here from this ultrasound in early December is normal, but another nice case of left ventricular myocardial calcium. And if it
The amazing thing is your LVs never drop. I don't, you would think that like there would be significant dysfunction with this, but I haven't seen a case where after this, the EF dropped because of this deposition. It's weird.
Yeah, so interesting. So that was a curious case. I think we've shown like 3 or 4 of these over the last dozen years or so, I think 10 years or so, 8 years.
Yeah, it seems to happen with pancreatitis, sepsis, shock, things like that.
Renal failure.
Yeah,
absolutely.
The
And
pancreatitis
it's amazing.
Yeah, major.
It can happen.
Maybe,
Sorry.
I don't know if that messes up calcium balance or if it's just the renal failure comes from the pancreatitis.
Yeah, one of my cases, my fellow sent me from Hopkins like many years ago, where like it literally developed in like 2 days. Like they had a CT which was normal, and then 2 days later there was just calcification in the heart. It was really, really strange. The same thing. EF was completely normal.
Yeah. 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 Okay, this one's interesting from several points of view. So let me first show the radiographs. At this point in time, this patient has mild interstitial lung edema, but that became worse. So that's on the 22nd. Here we have more of the same on the 25th. We have all the findings of interstitial edema that you'd like to see and teach with, particularly septal lines. But I do want to show you this. This is something that the Brits, I think, describe sometimes. And I don't see it very often, but they describe this right here as lamellar, Lamellar, lamellar effusion. But they do acknowledge that this is not fluid in the pleural space, but subpleural interstitial edema. So I think a very nice example, symmetric, of so-called lamellar pleural effusion. I don't know why some people develop this. I don't see it very often. In fact, very uncommon do I see this finding right there. It's not the usual meniscus of fluid. It's just a layer of subpleural, subvisceral pleural interstitial edema in the lung right there.
Why is it so thick? I mean, there's not that much tissue there.
Yeah, I don't know what does that.
Do you have a CT that shows that it's not fluid? I mean, I believe the subpleural edema and the fissures and such, but
yeah,
that's awfully thick.
It is thick. You know, he's got some subpleural edema related to the fissures. I don't have a CT at this time to go along with that. The CT that I do have is from a couple of days before, and he's got some mild edema then, but not too much, and a bit of pleural fluid. But that's what I think it is. You know, he's got interstitial edema here. This shows the etiology of his left atrial hypertension. He had aortic valve endocarditis. He has got abnormal non-coronary leaflet, maybe an abscess right there, aortic valve incompetence on echo. So the etiology of the left atrial hypertension is what you see here in the report of the ultrasound, right there. Okay, Jeff, those are my cases for this week.
Thank you, Howard. Those were excellent. All right, Travis.
Okay, I'll try again.
All right. 3 times, right?
I was able to change another setting, so we'll see if this works this time. There we go.
Yes, we're good.
All right, you should see my screen. Okay. You know, it's one of the nice things when you go somewhere new is obviously there's a whole host of cases that you've never seen before. And so Paige a couple weeks ago was like, have I ever shown you a case of X? And I was like, no, I've not seen that case. So this This is one such case, and this is a patient, and this was at an outside hospital, and you can see this patient diagnosed with PE, no diagnostic dilemma there, and they have a history of a glioblastoma. And they put them on anticoagulation. This is all still at the outside hospital, and I guess the patient had a seizure, and I don't know if the seizure caused the big hematoma or if the patient was just massively hypotensive and losing blood, which caused the seizure. But regardless, they ended up with this huge spontaneous hemothorax in their chest wall, in their pectoralis muscle from being on anticoagulation. So they transferred them here after placing an IVC filter and for further workup and whatnot. And Paige showed me this. So this is a CT that was done, and this is just a chest CT. It was done after they drained this hematoma, and I don't know how many days after. But this was an excellent pickup, and the technologists went lower than they should have, but they happened to notice this. Paige noticed this when he was reading the study and thought, that's not the IVC. And so this was an iatrogenic placement of an IVC filter into the abdominal aorta. And I have no idea, with the patient going downhill and stuff, there was descriptions of it being, the IVC filter being emergently placed so the patient could be stopped off their anticoagulation, whatever. I don't know what the situation was, but anyway, this patient ended up, and you can see it here on this subsequent plain film, with an IVC filter in the aorta. So they attempted to go in and, go ahead.
Did they let the other hospital know that they had done this? I mean, that's pretty freaking awful.
I don't know. This is a couple years ago.
No, I know. I'm just saying that is just nuts.
Yeah.
Well,
But
the
yeah,
other
so
thing is that it's, if it's in the aorta, it's facing in the wrong direction for blood flow. It seems to me this is not going to be that great for the legs.
yeah, I don't know. Well, this patient had a terminal illness with a glioblastoma, so they attempted to go in and take it out, and I guess were unsuccessful. So they ended up placing one in the IVC in the appropriate location. So if you want a radiograph or a fluoroscopic image to stump your residents with, here it is. So there's the IVC filter in the aorta and the one actually in the IVC. Yeah, David, you're right. The direction is not what it should be, but yeah, again, I have no idea how it happened, but it did, and it was actually a really good pickup that they were able to see that. Just on the inferior images of the chest CT. All right, this is actually a pretty tragic case, and this is a lady who we just recently saw an interstitial lung disease follow-up. I think this is, you can see this is 2020, in August of 2020. So it seems like long time ago, but this was a few months into the pandemic. This is a young woman who 2 months prior to this was able to go to kickboxing class for over an hour and not really get short of breath. And she's to the point now where she can barely walk 50 feet without getting dyspneic. And this is a PE study that was done, and this was at the outside hospital, and this was read as bilateral ground glass opacities. And of course, could be COVID. She had not tested positive for COVID, didn't have any exposures, and her symptoms didn't really fit with that. Then they did a repeat study, and this was actually when she was sent here the first time and was seen in the interstitial lung disease, as her symptoms haven't gotten better after 4 or 5 months. And you can see the appearance is almost the exact same. And of course, and I can pull these up side by side, the distribution of these abnormalities. And I think everybody on here hopefully knows where I'm going with this, but it's not actually these areas that are abnormal. That this lady has developed profound obliterative bronchiolitis. And I think other clues, just that there's reduced, there's a little bit of oligemia in these areas and smaller vessels. The airways are a little dilated throughout. And I do have expiratory imaging. Let's see here, I'll show side by side. And you can see on the expiratory imaging just how these are really the areas of normal lung that are still there, and everything else is just air trapping. And this fits with her PFTs and her physiology. And she's now on 6 to 8 liters. And so the question was, why did she develop obliterative bronchiolitis over such a short period of time? She didn't have a connective tissue disease. They did the whole workup for COVID, including antibodies, thinking maybe she'd had it at some point. She didn't. And I don't know, credit to the pulmonologist, but they started talking to her about some of her habits. And this during the pandemic, because she was not going out of her house, apparently she started mixing cleaning agents, including ones that had bleach. And so the thought is that this is from chlorine gas that she developed obliterative bronchiolitis. So a consequence of quarantine.
I thought you were going to say she started cooking meth in her house. Because I've seen a couple of meth cases where they do this, but
yeah,
with cleaning agents. But
I thought it was going to be
that's interesting.
overdosing on popcorn.
You've seen that. Yeah, right. She started just inhaling microwave popcorn.
Right.
But yeah, no, this was just apparently mixing cleaning agents, including ones that had bleach in them. So
and inhaling the fumes.
Yeah, I mean, it kind of fit with it was a pretty narrow time frame where she started doing that after she had run out of other stuff. And it coincided with this onset of symptoms. So I think she's on the transplant list now. She's not doing well at all. And then I'll just show this one really quick.
Has anyone heard of cleaning agent producing a desirable high? We just don't know.
No,
Okay.
I mean, this was not illicit. This was just her just cleaning with products that she had, run out of some products and trying to make others.
Oh, she was using the agents maybe to actually clean the house.
Oh yeah, no. This was not
Oh,
this was not at all recreational. I mean, she was apparently not going shopping because she didn't want to leave her house and was just trying to make do with what she had and mix bleach with other things.
Oh my gosh. Okay.
Yeah.
Okay.
And I'll show this one really quick. This is a patient that came in, and this is pre-pandemic. They came in with cough, fever, malaise, had this chest radiograph, and not taking a big breath, but there are some subtle peripheral airspace opacities, and of course this not so subtle big right paratracheal thing that's exerting mass effect. So I think this case is particularly appropriate now. I think Jeff was the first person to show a good example of influenza mimicking COVID early on. This was a patient that was influenza A positive, and this bronchogenic cyst or this right paratracheal thing happened to be an incidental finding. And now, if everybody's been reading the news with in my opinion, terrible portmanteau of flurona with these patients that are getting infected with both influenza and COVID, we're going to see both of these. And now, but this does look like a bronchogenic cyst and has been there. They didn't actually take it out. The interesting thing is it has gotten a little bit smaller and there's now a little bit of calcium, and it's not just milk with calcium, because I think the entire wall's calcified, and he's been asymptomatic the whole time, so I don't think it got infected. But curious what you guys think, because that was my one question, just with the change in morphology of this wall.
I've seen them calcify over time.
Okay.
That doesn't bother me personally, but I've seen it with both bronchogenic cyst and I even seen pericardial cyst calcify. So yeah.
I guess if they're there
long
enough. Yeah, we're starting to, there is flu going around here, still a lot more COVID, but anecdotally, the vaccine for flu doesn't seem to be working great this year.
Well, I think that was published early on just because the flu season last year was so mild that they didn't really have good new antigens to base the vaccine off of.
Right. Yeah. I mean, I know someone who their whole family was vaccinated, and the whole household got sick with flu, and it flu A. It was all positive PCRs. So yeah, keep an eye out for it. It's not all, although I mean, it's gotten so bad. I have templates now for positive COVID imaging studies because it's like every other one. All right. Seth, you got some cases?
Yeah, I do. Let's let's see here. So I'm going to beat your Flurona with this case. This is a patient with dense consolidation, left lower lobe lingula. I will tell you that it turned out to be Legionnaires, which is nice. And then the patient came back a little bit. Oh no, I have the wrong X-ray. Crap. Oh no. Anyways, so that's
Yeah.
Anyways, she came back a little bit later and actually had COVID as well. So she had Legionella on top of her COVID. So we called it Coachella for
That does
COVID,
work. Yeah.
COVID and Legionella. There's an extra
Actually,
C in there,
That's
but
Yeah.
it
I've got
almost
a couple
worked.
cases. Yeah.
was it a
Last summer, this made the national news, but Coach K had his like annual basketball camp, and there was a Legionnaires outbreak at Duke last summer during this basketball camp. So I'll pull up a couple of those cases in the future to show, but yeah, the Coachella is pretty good.
No, I have to, well, maybe Jeff's going, I'll pull over the follow-up radiograph, which shows that she actually has pretty good COVID pneumonia on top of it.
were there any
I thought
other patient? Was it an isolated case, Seth?
I don't know. That's a good question.
Yeah, it's just
Um,
unusual to see a random Legionella, but I guess.
Oh, she got another CT today. Well, that's good to know. So we can show you both of them a little bit later. But I'll try to pull those up later. Oh, let me just show this one real quick because this is one of the more subtle things that I still had trouble seeing, even though I knew it was there. So this is a patient with hyperparathyroidism, and you're kind of looking for the parathyroid adenoma, and you don't really see anything. I'll tell you, there is this little soft tissue here, which is right contiguous with the vessel here, also contiguous with the kind of soft tissue of the sternoclavicular joint. And there is a follow-up study. Let's see if I can find one here. I think you can see it best on the sagittal, but that was probably the most subtle. Let's see if I can't even see it here. Where is it? One of the more subtle, here it is, this little thing up here. One of the more subtle parathyroid adenomas. Here's the nuke med, the fused axial imaging. Just do 2D. Oh, that's the wrong one because it doesn't have the, here we go. Okay, well, this is a great case all around because I can't even show it to you. But trust me when I say, if you scroll down the little thing on down here, you can see down here the little area of uptake on the Sestamibbe study showing that this is in fact a little parathyroid adenoma. So it's just a very subtle thing. This is an interesting case. I will show the delay first. So this is a patient with a basically hypoplastic left heart. You can see this tiny little LV here. It's all right heart. That's undergone a Fontan. And this is an older study. You can see there's a stent in the PA. He's also got stents in the pulmonary veins. His pulmonary veins were kind of narrowed. And he's developing some edema in the left lung. And I'm not sure what decision was made or by who. And this is, again, quite old. So that was, first study was in 2011. Someone decided in 2014 to embolize, put actually kind of occlusion devices in the left pulmonary artery and occlude the LPA. And since then, he's had profound edema in the left lung. You're like, well, why does he have profound edema in the left lung? I'm assuming they thought because both of the pulmonary veins were severely narrowed that they would actually be doing a beneficial thing for him. But, oh, Lordy, sorry. Let me load this again. So there's a couple interesting things on him. One is the issues with the Fontan, which I'll show you in a second, which is a very common thing we're asked to kind of image these days, which is really painful. The other thing, you see the occlusion device, but you still see there's rampant filling of the pulmonary arteries. And that's because the body's pretty good at developing these very nice, huge bronchioles, which are supplying the basically the entire left lung. And because you have this, pretty robust arterial supply, systemic arterial supply, but he has no venous drainage, You can see that pulmonary vein is gone. This pulmonary vein is pretty much gone. And this one was almost out. This is not the right phase. This one was out here, that he was developing basically, as you would imagine, venous stasis in that left lung because you can't drain it. The other interesting thing is you can see all of these massive collaterals. So this is a different issue. So we often see in these patients with Fontans, very severe increased in right atrial pressures, right heart pressures, because of just the long-standing Fontan physiology. And because of that, the body is, again, quite adept at finding collateral pathways. So you have all these systemic venous collaterals, which are all arising from the systemic veins. And they'll usually do this. They'll dump into the pulmonary vein. And as you can see here, which I'll show in a second if I can I have a good video of it. Oops. Let me play this. Pretty robust filling of the right inferior pulmonary vein from these collaterals. I mean, it is pretty impressive. So this is just a massive shunt, where most of the systemic venous blood, at least coming from the upper extremities and the head, are coming into the pulmonary vein. And then additionally, you can see this beautiful intercostal collateral coming through and then dumping into the pulmonary veins. So a really impressive case of two things. One is the bronchioles supplying a lung after they embolized it. And the second is the systemic venous to pulmonary venous collaterals in the setting of Fontan. And this patient had to undergo a heart-lung transplant, because when you hit to this point, you're pretty much, they go in and they try to embolize them. It just never really works. It's like just putting, fingers in the dike. I mean, you're just closing up one pathway and then another one will pop open. So this is a case where you can see right-sided arch, weird looking heart, lungs okay, kind of maybe some subpleural thickening on the left, right, not completely normal either. I don't pick up any rib notching per se, maybe a little bit. I wouldn't call it prospectively. This patient underwent a CT, and it's really impressive. So let me show the, let's see if I have it on here. Here we go. So let me show you the physiology first real quick. So this patient has double inlets, single outlets physiology. So with detransposition, here's the 40 flow LV, RV, with the single outflow tract going through a VSD into the pulmonary artery. Now they don't actually call these for some reason they don't call these VSDs when in the setting of a single outlet chamber. They call them, what do they call them again? I can't remember. Bulbal ventricular foramens. It's basically a VSD that allows for flow between the outflow chambers. But I'll show you something that's interesting, which leads to the imaging findings on the CT. So here is this, it's a detrans. Here's the pulmonary artery behind here. The pulmonary outflow tract is very stenotic. The valve is domed and very dysplastic. Here's the VSD, the bulboventricular foramen with the single outflow tract through this massive anterior aorta. But the interesting thing is that even though both pulmonary arteries are well formed, there's really, and we associate pulmonary stenosis with increased flow into the left PA, but here there's like almost no flow into the left pulmonary artery. You can see this impressive swirling of flow in the aorta, this anterior aorta. So this patient has basically all the flow from his, the portion that's going through the pulmonary artery into the right and not to left. So then let's go to the CT, which I think you can then understand some of the findings that we're seeing on that. So this patient has it's uncorrected. She's from the Philippines, never got it corrected. You can see this very dysplastic, domed bicuspid pulmonic valve right here, this thing that's very severely stenotic. when I do kind of a more in plane view, I think you can appreciate the actual physiology or the anatomy isn't as complex as it actually looks on some of these other images. So here you can see this is the D-trans, right? So this is the kind of mitral, this is the RV separated from the conus, separated from the inflow valve, leading to the anterior aorta, and then the more posterior lesion is, or most posterior outflow tract is the pulmonary artery. Anyways, long story short, this patient also has an ASD. You can see these really dramatic collaterals on the left. These just absolutely massive systemic arterial collaterals from the subclavian vein and the intercostal, subclavian artery and the intercostal arteries. And those are all feeding the left lung. So it's almost like you would see in those cases where we have, proximal interruption of the pulmonary artery or genesis of the pulmonary artery. But because there's just, even though there is a PA, there's just no flow into it. So what they did is they created a neo RVOT. I can't remember. In a kid, it's called a Sano. I don't know what they call it in an adult, but they basically create a neo RVOT. They ligate the pulmonary artery here. They cut it out. They create a new pulmonary artery. But look what's happened to those collaterals within a few weeks. So those collaterals, which were massive, that were being there to supply the left lung, have literally decreased, multiple fold from just doing this procedure to bypass whatever was causing that flow restriction. So interesting case.
Yeah.
And then lastly, just real quick, here's another case of something. And man, I guess there's some unilateral rib notching. Technically on this, both of them should have caused more pronounced unilateral rib notching. This is a kid with coarc that I don't understand it. So the valve has been fixed. He's got bilateral SVC, but the coarc is still quite pronounced. And then he has all these massive right-sided systemic collaterals. Look at the right internal mammary, left is normal. And so this is just a really impressive coarctation. Let me show you so you can see if I can find it here. Sorry, I put this up. Let me know if you can see this. Let me repeat this. So here is this very weird aorta with this really severe coarc. But I'm not really sure why the coarc has, I always assume coarcs usually have bilateral collaterals. I'm not sure why this coarc has, and I know it's supposed to be where maybe where the subclavian artery comes off, but I'm not sure why there is unilateral collaterals with this really bad coarc.
So if the coarc is proximal to the left subclavian, then the left side will be spared. So the
but I guess the
is on the high pressure side of the stenosis. So can you tell where it is in relation to the subclavian?
So here's the coarc. Well, it's okay. You can see here's the narrowing. Here's the subclavian here. So it's right there.
Yeah. So that subclavian is pretty narrow. So I think the subclavian is being stenosed. So that's the reason. So
even though the coarc is distal to it, it's still just narrow enough to where it's causing the same physiology.
Yeah, so the subclavian would be big if it were on the high pressure side. So I think it's downstream from the obstruction, or at least some part of the obstruction.
Okay.
Because it would be huge if it were proximal. The way the right one is, see how big the right one is?
Yeah, no, the right one's absolutely massive, yeah.
So the left one is downstream from the obstruction.
Yes, no, it is. It is quite, okay. I remember I had to do something with the position of the coarc in relation to something, but that makes complete sense. But that's less common, correct?
Yes, it's typically distal to the left subclavian.
Yeah.
Yeah, interesting.
So, Seth, I had a question about your previous case. Was that it looked to me as if there could be left bronchial isomerism in that previous case?
This case, there is. There are a lot of anomalies here.
Aorta's going down.
Wait, is this the one that's, no, this one is, no. So here is right upper lobe here. And I think the interlobar, I'm sorry, the bronchus intermedius here.
Oh, you're right. You're right.
No, and there's the left. There's one I had recently that was not this complex. That was an unknown isomerism with stuff,
Yeah,
like polycythemia and all that stuff. This one was not.
Very helpful. Yeah, thank you.
Yeah. Sorry, Jeff, I went long with cases. So
Not a problem. Mine are pretty fast. Those are cool. Thanks for showing that complex stuff. Let's see.
But it's just interesting, the physiology. But that's really, man, it's funny. I knew it had something to do with that subclavian, and I was Googling it like crazy, and I couldn't find anything online before conference.
All right. I will start with this one. This is just an artifact to be aware of. You can see this was a very large patient, and you see all this artifact. This is done with a DR unit, and all what looks like electronics. You can make out some chips, a bunch of capacitors, resistors, all that stuff. So this is a backscatter artifact. When the dose is too high, you get backscatter off the electronics of the detector, or even in some of the equipment. This patient was, I can't remember how big, but you can see quite large. And this is with full maximum dose on this machine. This is not one of our better portable units that has a bigger generator, but just something to be aware of as a artifact of the DR world. If this were film, you would have just burned through it. And I don't know what you would see with CR, probably similar, just lose contrast, but that's what this is. So this is a backscattered artifact from dose. It's like 10 times the normal amount. This is a cool case one of my colleagues shared with me. This patient had has a, I think it's colon cancer, but had liver metastases, and they were treated with microwave ablation. And there was this one area right up here, what looks like a lung nodule. I'll make it a little bigger for everybody. But you'll see there's some fat associated with it, and it's really smooth and straight. So it may not actually be in the lung. And then what was, I think, an astute observation is this little defect right here in the diaphragm, and there's some stranding in the subphrenic fat, and a little bit over here too. And what's helpful is to go back and see the ablation CT, and you can see there's the antenna coming in, and it was passing right in that area along the liver. You can see there's one of the lesions there. That may have been partially treated. Yeah, you can see an antenna tract in there already. But sometimes I don't know the ins and outs of how they do these all the time, but there's clearly a zone of injury. So after looking at this, I think the suggestion that this is a small amount of fat necrosis with a small diaphragmatic defect, I think was a good observation right there as a complication of ablation. It's probably going to be of no consequence, but it wasn't really a true lung nodule. So that's the first time I've seen that related to the ablation.
Good.
And then, yep. And then this last case is kind of crazy. So this patient had esophagectomy and a bunch of problems with that. Ended up in discontinuity with a spit fistula here, and you can see no esophagus. Just they had a colonic interposition in the substernal prevascular mediastinum. Well, that had problems and that broke down. So they ended up having to build a new neoesophagus. And they did this, and I don't have the OR pictures, the surgeon showed me them on his phone, but they took a giant free flap from his thigh. And so this is skin, and they folded it over to make a tube. And this is purely for saliva and oral secretions, not for eating, as you can imagine, but to avoid having a spit fistula. So they you can see there's the drains there. So it was jointly done with plastic surgery, and it's subcutaneous at this point. They removed the colonic interposition.
Wait. So what's the hole? What's it going through? It's muscle.
It's a whole free flap from the thigh.
So the fat I see, and then, but what's the how do they make a little conduit for fluid secretions to go
They
through?
use skin. It's a skin flap.
Oh, how wild. Okay.
Yeah, I've never seen anything like it. So this was him immediately post-op, and they've got a bunch of drains in and they've got it covered with pec muscle and all that. Well, unfortunately, this suffered complications and started to fall apart. And you can see if we go here, there's still, this is about, let's see, this is about 10 days later, and you can see it's opening up. It's not contained anymore and communicating there. And now there's gas going up along the sternum there, but there's really not much in the way of fluid in that area. Down low, there's a little bit more. You see there's the conduit right here going down, and then it connects to what's left of that colonic interposition there. And then is continuing not to do well. I mean, the patient's actually doing fine, but this flap is not, and I think they've managed to figure it out. But now you can see it's opening up further. So there's this channel, but what's happened is the drain that was in this lumen has flipped over here. There's two drains, and this is actually one of them. So what's happening is it's preventing this tissue from approximating this tissue to allow it to sort of fuse and close down. So they were able to back out the drain and let it fall into the lumen, and then hopefully the thought is that this would close down. But I have never seen this before. So this is a giant, and he doesn't have any more donor tissue. So a giant free flap from the thigh that they brought up, covered with pec and skin, but it still has that. You got to worry about this getting that sternum getting infected. But because even though he's not eating through it, there is still saliva and stuff going through it. So yeah, that's a new one for me. I mean, colonic interpositions are pretty uncommon, but I've never seen a.
Probably won't do it again. It doesn't.
Well, it's kind of cool. What they did is they took an esophageal dilator to size it, and they wrapped it around it. So they used it kind of like a template.
That's so strange. That's fascinating.
But it's it's a good vascular. I mean, it's a healthy flap mostly. I mean, it's not necrosing or anything. You can see that. It's just not sticking down. So with the veins in the way, and hopefully with them having backed them out, this thing will close down. It'll just adhere to the anterior chest wall muscle right there and avoid, and then this will just become a conduit, and it'll have an epithelium, so it won't get infected. And it's got a healthy blood supply, so that's good. But it's just crazy. I've never seen anything like this before. And it's funny, on his chest radiographs, you can barely make it out. You'd have no idea that this is there.
No.
So Jeff, tell me about this flap. They didn't bring up the blood supply. That's pretty far away to bring it up from.
Right, it's a free flap. So they did the microanastomoses.
Got it.
Here it is in long form. You can see just how big it is. Yeah, he showed me the picture. They just cut out like a rectangle size thing, and then they measured it over, and they used the esophageal dilators of kind of how big to do it, and they folded it over and put the open in against the prepectoral, the subpectoral fascia and the intercostals, and then use the rest of the flap under the pec, because there's no defect in there, and to keep it protected from the outside world. But it just needs to close down. So hopefully as they back out the drains, it'll sort of just seal itself off. It's kind of cool. It's really creative. I'm sure there's plenty of literature on this, but it's just not something I've ever seen. But it's sort of a last resort. Usually they do colon if they can't bring up the stomach or something. They don't like to do jejunum because it doesn't give them really any reservoir whatsoever. I mean, I've seen a couple esophagojejunostomies, but that they can barely eat because it doesn't go anywhere. But this is just to get rid of the spit fistula and all those problems associated with it. Okay, well, it is the hour, and those are great cases.
Hey, Jeff, can you let me show I pulled up that radiograph. It's not that impressive, but it's
yeah, let's see it.
It's just a better I guess name amalgamation. But here's the COVID, and then here's the residual of the Legionella pneumonia, which is getting better slowly. So
again, it was Legionella first and then COVID.
Legionella first and then like 3 weeks later, 2 weeks later, got COVID.
Wow.
So yeah, we're calling it Coachella. We do like that.
All right. Well, thanks,
Most
everybody.
amusing thing I've ever come up with, I have to say. Okay. All right, guys, take care.
Talk to you all later.
All right,
All
bye.
right.
Everyone, thanks.